Thank you to the organizers. I was tasked with the clinical evaluation of coronary involvement. So for me, when I'm thinking about clinical assessment in Kawasaki disease, I think about echocardiography because they really go hand in hand. So I'm going to talk a little bit about the whens and whys of echocardiography with some tips for imaging potentially consistently so you can get the most accurate data out of your scans. And talk a little bit about the evolution of coronary artery changes as it relates to our clinical assessment and imaging needs, and then talk a little bit more about integrating our multimodality imaging choices and perfusion tools over time. The diagnosis for most children more than a year of age for Kawasaki's is based on clinical criteria, so you really don't need to do an echocardiogram before starting IVIG if you meet the clinical criteria that Dr. Neuberger went over. However, echo is a vital tool in the diagnosis for those who have incomplete features, as from this very familiar algorithm from the 2017 guidelines for patients who don't have all the clinical features. But I was going to just highlight a few clinical circumstances in particular that I think are worth considering on obtaining echoes in particular, and maybe ones that we don't always think about. So one is if there's infants who have unexplained fever of at least 7 days and they have elevated inflammatory markers. Another group are patients of any age actually with persistent fever with lack of response appropriately to antibiotics, including those to strep, cervical lymphadenitis, or those who have this non-specific inflammation or phlegmon in the retropharyngeal area. So this was one of our patients who was an 11-year-old actually, who was diagnosed with Kawasaki disease with this very large right coronary aneurysm dilation. He was diagnosed at day 18, and he had been treated with antibiotics for documented strep and then also was tested positive for adeno. So you do have to keep a high index of suspicion. Another thing is that you can't put your echo machine away if there are concurrent respiratory viruses, because they generally don't exclude the diagnosis of Kawasaki disease. RSV, metapneumovirus, coronavirus, paraflu, influenza, they can all happen with KD, and in fact the last 2 KD patients we just saw here at Texas Children's were admitted with RSV bronchiolitis first. And then just to mention about the adeno thing, if it's a positive PCR and there's an exudative pharyngitis and conjunctivitis, then probably KD is unlikely. But if it's non-exudative, then I think you can't exclude Kawasaki disease. Another group is the febrile patient who is suspected to have bacterial sepsis but is not responding to antibiotic therapy appropriately. This brings up the question of Kawasaki shock. There's some information to say that about 7% of patients in continental US do present with shock, which is defined as needing volume resuscitation or inotropic support or intensive care. And one of the hallmark features is, like in this patient here, it's not so much LV dysfunction, which in this case looks relatively reasonable, but a pretty dramatic drop in peripheral vascular resistance requiring fluid support and inotropic support. So this patient was on fluids at the time of the echocardiogram, and you can see that there's a little bit of mitral regurgitation, but again, the function really isn't bad. So these patients with Kawasaki shock are at higher risk for IVIG resistance and coronary artery abnormalities, and in fact this CT scan shows the giant coronary aneurysm that occurred in the patient whose images I showed you on the preceding slide. While most times patients with Kawasaki disease that they have ventricular dysfunction early in their course that gets better very quickly, for those with Kawasaki shock it can be prolonged, and they deserve follow-up for that over time. So one thing about Kawasaki disease is when is an echo considered positive? Well, so it's pretty obvious if there's a coronary artery aneurysm, but if there's just dilation, how much is too much? Well, if the proximal right or the LAD has a z-score of at least 2.5, then that counts as a positive finding. There are also a conglomeration of suggestive features. So if you have at least 3 of these, so decreased LV function, which can be found on 20% of baseline studies, which also means that not everybody who has LV dysfunction has Kawasaki shock. A lot of those are asymptomatic. There's also about 1/4 of patients who have mitral regurgitation, as you can see on these images. Small asymptomatic pericardial effusions can happen pretty frequently, as you can see in the upper right screen. And then there's the sort of tweener coronaries. So those are the patients who have sort of borderline dilation. So it's not quite normal, but it's not the more than 2.5 z-scores. What's not considered a suggestive feature anymore because of their subjectivity and poor reproducibility are the lack of distal tapering and the perivascular brightness, which, as you can see on that last set of images on the right, can be really impacted by gain settings on the machine. An interesting thing that is not on the list of features but can be found, and sometimes we scratch our head over, is this diastolic flow reversal in the abdominal aorta in the absence of significant AI. And we think maybe that's because there's increased distensibility related to inflammation. That usually goes away after treatment too. One thing I will point out is while a positive echo supports the diagnosis, a negative echo does not rule out Kawasaki disease, so you have to put all the assessment together to really support the diagnosis or not. So I talked a little bit about a baseline or initial or diagnostic echocardiogram. For the second echocardiogram, it's generally recommended that that be about 2 weeks after the start of fever or a week after therapy. And when we see these patients back in clinic at this time, a lot of them are totally fine and raring to go and rambunctious, but some are just not quite back to normal. And what I've seen is that sometimes they'll report difficulty sleeping, or their appetite's not as good, they're not quite as energetic, or they may even have some evidence of some joint discomfort with a sort of lingering arthritis. And in those patients, I do consider checking inflammatory markers to make sure I'm not missing an opportunity for treatment to prevent the coronary artery progression or abnormalities to develop. For those patients who don't have a smooth course, a second echo should not wait for a week. If your initial echo is abnormal, if your inflammatory markers are rising or at least not subsiding, or if you have recurring or persistent fever or other signs of persistent inflammation, red eyes, red lips, undue irritability, then I think those patients deserve an earlier echocardiogram. Dr. Neuberger touched on these risks for aneurysms on WHO. I'll just point out that yes, we still do see patients older than 8, including that one with the strep that I mentioned to you before. And then on the young side, I think that most of us focus on the under 6 months of age. The Cameron et al. Group did publish in 2018 this information that says it's really everybody under 12 months of age who you need to be worried about. While infants less than 6 months, 68% of them had aneurysms, which is a whopping number. But for those who are older than 6 months, 40% had aneurysms. And then another risk is just to remember that that Z-score of more than 2.5 is also predictive for the development of aneurysms over time. So 2.5 is a good number for Z-scores to remember as far as significance on that initial echocardiogram. Dr. Neuberger went over the Z-score classifications. I'll just mention that not all of the Z-scores carry circumflex Z-scores, and so these two that I've listed here and are available as online calculators do. Another just point is that the Z-score accuracy really depends on an accurate body surface area and which height significantly contributes. And so when you think of irritable toddlers and infants, you really have to make sure they're stretched out and measured accurately from time to time, or otherwise you'll have these wild swings in Z-scores you don't know what to do with. And you have to, if you're going to be using online Z-scores, make sure your lab is using the same one from patient to patient so that you're not mixing them up, because they will have different measurements, particularly at the upper end. When you're thinking about imaging for aneurysm evolution, think about where they are. There is a predilection for branch points, like but where the main branches out into the left anterior descending and circumflex, probably because of a shear stress phenomenon. Proximal sites are affected first and most frequently, and it is unlikely, we think, to have distal involvement without proximal. So it is important to assess all the coronary segments. And that means you need multiple views. It's more than just the parasternal views, and you need to have your lab be practicing and diligent. The PHN study in 2011 did show that there's hope that we can get better at our coronary imaging, particularly the distal right and circumflex, if you practice over time. And then another helpful hint that emphasizes that sedation really helps. Not imaging a moving target really helps you to visualize all your segments of your coronary arteries more effectively. When you're looking at how to get the best images, you can also think about things to improve your resolution, including things like highest frequency transducer possible, trying to maximize your frame rate, centering the coronary in the middle of the picture, and when you're doing Doppler, to put the flow parallel to the vessel whenever possible. And to the point of the gentleman who's asking about, well, how do you get those luminal dimensions so accurate? I think you, well, one, you're measuring inner edge to inner edge, and you really want to try and have your echo beam at right angles to the arterial wall. But I also find that I go back and I do my own measurements, so I make sure that the patient is being measured at the same point from study to study to study, because If you're just a little bit downstream or upstream, all bets are off. It's just kind of helpful to think about where those coronaries go when you're looking at them by echo. And so when you're thinking about the peristernal short axis view, if you are at the level of the aortic root, you can do a little slight clockwise rotation, and then that should bring out your left anterior descending. And remember that the distal LAD is just past the pulmonary valve annulus. When you are looking at the left main, you want to measure it at its midpoint. Don't do the proximal portion because you will have falsely high measurement. And remember that left main coronary dilation rarely occurs without associated dilation of the LAD or circumflex. And left main involvement does not typically involve the orifice itself in Kawasaki disease. So then when you are looking in a peristernal long axis, you can also sweep right to left between the aorta and the pulmonary artery to demonstrate the left main and as it branches into the left anterior descending and circumflex. And then moving to the apical, you can, this is an obvious case, but you can see that dilation of the circumflex in the left AV groove. That's sort of a bad thing to see. And then when you can also look further by sweeping anteriorly, and you can go from seeing the circumflex in the left AV groove, and then you'll see the left main, and then if the LAD is dilated, you can see it staking all the way down the septum. Don't forget subcostals. You can do LV long axis to see the circumflex. And then when you go to the subcostal coronal, you can see the LAD running down the septum here. This one also had dilated right coronary artery, so it's bad news all around. And then you can do a long sweep, and in this case, the circumflex is wrapping the entire way around and is dilated throughout. So you can really get good information from your subs as well as the other views. And then in thinking about the right, it's the same thing. In this case, it's a right dominant with a posterior descending coming off of it. So at the peristernal short axis, you're back at the aortic root with a slight clockwise turn. And remember to measure the right coronary after the initial rightward turn. Again, you don't want to have a falsely elevated measurement as it comes right off of the aorta. And follow the right coronary laterally. Move to like a right peristernal. Even having the patient moving to their right side can be helpful in getting these ones where you see this all the way out to the AV groove. You can get that from a peristernal if you position your patient properly. Sometimes just doing a peristernal long axis, you can see the coronary coming off anteriorly. That can be a view that can be helpful. And then you can angle towards the tricuspid valve and the lateral AV groove to see the right coronary artery and cross section here. And then angle posteriorly further, you can see it as it goes back behind, and you can see if the posterior descending is dilated. The apical can also be helpful. You're scanning the right AV groove anteriorly for the proximal and mid portion, and then posteriorly you can see the distal AV groove to assess the distal and the right PDA junction. So it's all about taking your time to do sweeps and to really go back and forth, anterior to posterior, and really scan the whole length of the coronary. When you're looking at subs, you can go to the view of the right ventricular outflow tract to see the right coronary artery coursing down the right anterior wall. And then in a subcostal short axis, you can follow it along the right AV groove, and in this case, you could even see color Doppler in that little chain of aneurysms along the way. On a LV's long axis sweep, you can even see, the right coronary artery. Let's see what happened to that guy. The posterior descending can be seen from subcostal. If it's dilated, you can see it running along the inferior aspect near the diaphragmatic surface there. So that's just sort of a brief how to think about scanning and making sure that your lab actually looks at all those different regions. When you're thinking about the timing for the third echocardiogram, generally we're doing that about 4 to 6 weeks after treatment if there's been a normal clinical picture and normal 2-week echo. And the information that Dr. Neuberger touched on by DeFerranti et al. In 2018 was reassuring that if you have normal first 2 echoes and everything is measuring normal, no distal aneurysms, that 98% remain normal at the 6 weeks of illness. The only caveat about that is that was from 2 tertiary KD care centers, so maybe a little bit of patient selection there, but that'll be something for us to look at over time to see whether everybody needs to have the 6-week echo or not. In uncomplicated KD, I think that there's some thought that you can just consider dismissing the patient from clinic at 6 weeks, and I know we'll talk a bit about management tomorrow, but I would say that one thing I would touch on when I'm dismissing patients at that point is the potential for recurrent KD. 1.7% doesn't sound like much, but it's 10 times the overall chances if you didn't have KD before, and that siblings can develop KD. We probably have about 5 to 7 families that we follow here who've had a sibling present within a couple of years of their the first child in the family having KD, and not all of them are Asian actually. And in those groups that we're dismissing, we do talk about a heart-healthy exercise and nutrition prescription, trying to encourage active play and heart-healthy eating. And just touching a little bit on the situation in complicated Kawasaki disease, we advocate that you need to image frequently and keep a close eye on them, because like in this patient that we had, went from just mild dilation on a first echocardiogram to this really nasty, severe dilation of the left anterior descending and circumflex within a week and a half. And so if you are not careful, you'll miss the opportunity both to potentially offer therapy for anti-inflammation, but also prevention of clot. The highest KD mortality happens to be in the first 15 to 45 days, and that's usually associated with thrombosis and these rapidly dilating aneurysms. And MI can be silent or with nonspecific symptoms such as irritability, particularly in infants. So again, minimal twice-weekly scanning while rapidly expanding. And this is just to show you that this is this one patient who had a severe dilation in their coronary artery. And you can see by color Doppler here that there is good flow here. But then as you scan here, that all of a sudden the nice black lucent field is gone, and this is a big fat thrombus in here. And when you look here, you see very little in the way of flow. So these do happen and do offer the opportunity for upping your anticoagulation, antithrombotic regimen to try and save that coronary artery. This will be touched on tomorrow during the management section, but it does make a big difference about what you're going to be offering therapy-wise based on the size of the aneurysm and how complicated the aneurysms are and how rapidly they are evolving. So just keep that in mind. And then there are definitely times when you need to do advanced imaging in the setting of acute Kawasaki disease, and usually that's when you're not sure whether there is distal disease or you suspect that there is, and that may alter whether you need to add Plavix or add anticoagulation otherwise to the regimen. So in general, I would say that we prefer CTA as the initial imaging test for acute KD, because generally we're not needing to have anesthesia. You can bundle the infant and do it with an IV. And it's a good test for looking at whether there is a thrombus, or to follow that over time. It's better than MRI. This is from the guidelines showing this problem with the myofibrillary proliferation that we were talking about. How, although your lumen dimensions may normalize, the vessel walls may not be normal, and that this can go on to stenosis and occlusion. This is just an example of that from our own files here. So this was a patient who had giant right coronary, multiple aneurysms in a row, and then within a 2-year period, actually the angiogram would make it looked like it was totally thrombosed over time, and then another 2 years down the road, another angiogram shows these multiple little collaterals that develop. And I guess that's one of the good things in Kawasaki disease, that there's this spontaneous revascularization that can occur where there's new tiny arteries braid together within the old lumen or vessel wall, and they call this arteriae and arteria. So this is an intravascular ultrasound just showing these twisting of the little vessels, which I thought was a cool way to look at it. It has the potential to really save the myocardial perfusion in those patients. It's not ideal, but it sometimes does quite well. I've had patients who've totally occluded a vessel or another and have not had any change in ventricular function because of that. So I know that this will be the basis for the talk tomorrow, so I'm not going to touch base on it too much, other than to say that the long-term evaluation and management is based both on what the vessel size looked like to begin with and how it is currently. But do keep in mind that there are other factors beyond aneurysm size which may increase the risk for ischemia, including the greater length, complexity, or number of aneurysms. Whether a patient is developing collaterals or not. I have one patient right now who is not developing collaterals and sort of at our wit's end to try and help that patient's vascular supply. And poor ventricular function is also an adverse prognostic feature. And so when I'm looking at these patients over time, I certainly do inquire about chest pain with or without exertion. Chest pain without exertion, you know, usually in children we like, it's nothing. In Kawasaki disease, I still pay attention to chest pain without exertion. I'm always asking about whether they're exercising and actively playing, whether they have palpitations or other evidence for arrhythmia, and I inquire about any new family history of KD or early cardiac risk factors. But I just want to point out that a lot of times these kids can have asymptomatic progression of coronary artery disease, and so you have to stay on your toes and you need to rely on a combination of testing, of imaging and perfusion assessment. So this was just to bring that home. I'd say that these are two EKGs of a patient I follow who's now 12 years old, and this EKG on the top was when he was 2 years old and was about a year and a half out from Kawasaki disease with giant left and right aneurysms. And it looked pretty okay on the top, and then 6 months later when he came back, you saw all these huge Q waves and he had had an inferior infarct. In inquiring with the family, it was like, did he ever have any episodes of irritability or pain or anything? And the answer was no, 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 except that when he was trying to evacuate with Hurricane Rita, that was several years ago. You may remember that it was a big deal. Hurricane Rita, the city just came to a standstill and there was multiple people stuck in highways for hours and hours and hours, and this kid had a GI illness and was stuck in a car in a highway for 12 hours and was very dehydrated and was crabby as all get out then. So we think probably he became dehydrated and thrombosed off this lovely coronary at that time. And this lower MRI is actually what his myocardium looked like. You can see he had this nasty inferior region of infarct. So when you're looking at the long-term imaging for these, I know we're going to hear from Corey and from other folks here about MRI and CT. We try to use a combination of things and tailor it to what's best for the patient at that time. And probably you're not going to do just one or just the other on any given patient. MRIs are great for perfusion, both at rest and stress, looking at scarring and function, and CTA is really helpful about evolution of stenosis and distal or complicated disease and thrombus. So we do far less caths now than we used to. I do that if we are suspicious for stenosis or if it's not clear on CTA or MR, or if there's a suspicion for ischemia like symptoms, abnormal stress test, arrhythmias, or a change in function. I do think cath is better for looking at collaterals and for assessing intervention. So this was a patient who, looking at her, you would think that there wasn't really anything going on there after the right coronary artery, but we knew that there had to be something because RV function was normal. And so when we looked at the cath, you could see these little areas of collaterals filling here, and it was actually enough to keep that right ventricle healthy over time. And this is just a quick look at a bypass graft by angiography that can be really seen well and is obviously doing great. Stress test is a whole nother category. One thing I would say, just remember, is that plain stress test, just climbing on and looking at the EKG, is not enough, not sensitive enough in our patients to assess for at-risk myocardium, but I do find it sometimes helpful in making sure that they're not going to be having arrhythmias before going out and playing athletics if they're being followed over time. So in conclusion then, I'd just wrap up by saying it's not just infants under 6 months, it's under 12 months, that viral syndromes generally don't preclude KD, that coronary dilation on the initial echo of at least 2.5 is both consistent with KD and an increased risk of aneurysm, and that this KD vasculopathy and persistent or regressed aneurysms or dilation really require ongoing multimedia imaging and perfusion assessment and staying on your toes clinically. Thank you.